Okay, we're going to go ahead and finish up tuberculosis with nursing actions. Of course, you want to monitor respiratory status. This is the source of our issue. Breath sounds, cough, sputum. Nutrition as well is one of those admitting diagnosis factors is weight loss, night sweats, those sorts of things. So they're going to have nutrition less than body requirements typically. So we want to really encourage good nutrition. Medication administration is going to take at least 2 weeks to get 3 negative SFS bacilli sputum cultures and then 6 months to actually clear the infection. Your patient must be in a negative pressure room so the air does not mix with other patients' air in the hospital. It's called negative airflow, negative pressure. This will dilute the concentration of the droplet nuclei within the room and help to prevent their spread to adjacent areas. Staff must wear what's called a PAPR hood, P-A-P-A-R hood, which is specifically fitted mask to care for active TB patients. When that patient is outside of the room, they must wear a mask. I always want to just think hygiene, hygiene, hygiene with tuberculosis patients. You want to discard any tissues in the garbage, not on the floor. Nurses could pick that up. That's what we do. We pick stuff up off the floor and throw it away. So really want to just kind of keep all your P's and Q's together. All right, so medication treatment for tuberculosis patients. Chemotherapeutic medications are used both to prevent and to treat TB infection. The goals of treatment are to make the disease non-communicable to others, reduce symptoms of the disease, and effect a cure in the shortest time possible. Prophylactic treatment is used to prevent active TB. Patients with recent skin test conversion from negative to positive are often started on prophylactic therapy, especially when other risk factors are present. Prophylactic therapy also is used for people in close household contact with an individual whose sputum is positive for bacilli. A single drug therapy is effective for prophylactic treatment, whereas active treatment generally is going to involve 2 or more chemotherapeutic medications. For newly diagnosed TB is typically treated with in the initial regimen of 4 anti-tubercular medications: INH, rifampin, pyrazinamide, and ethambutol daily, several times per week on a decreasing schedule or frequency for the first 2 months of treatment. The initial regimen is followed by at least 4 additional months of therapy, with INH rifampin given daily, twice per week or weekly. If patient has HIV infection, treatment is continued for at least 9 months. On table 3-6 on page 1135 in your book, very nice summary of the anti-tubercular medications. The one thing that you want to keep in mind, 2 things actually with rifampin, you really want to teach your patients that it turns every body fluid orange. Tears, urine, any secretions, saliva, it's going to turn orange. So you would want to, of course, tell them that so they aren't scared or afraid. Almost all 4 of your 4 cocktail medications of the newly diagnosis are hepatotoxic. So if you have a patient who's an alcoholic or a patient who has liver enzymes that are impacted, really, really have got to watch that liver very closely. That streptomycin on the bottom is one that can be used as well, and it's nephrotoxic. So really want to take a look at which medication you're using and where it's processed. So the difference between latent TB and prophylaxis. So with our latent TB, you're going to have a positive, okay, sorry about the latent TB, which means it is present in their body but not active. So they're going to have a positive TB skin test. We're going to follow up on a chest x-ray to make sure that it is latent. Once it's positive, that skin test is always going to be positive. So there, we're going to go ahead and treat that with INH 300 milligrams daily for 6 to 12 months. So let's say you have someone who is very, very much at high risk, living in close quarters. They're going to prevent that and give the INH daily for 6 to 12 months. And then those living in those developing countries, this vaccine is not given in the United States. This is only given in countries where people are, the population is very, very much at high risk. That's that BCG vaccine, and again, not given in the United States. All right, to finish off, we'll talk about just fungal lung infections. Some different kinds. We've got the histoplasmosis, can be found in soil or bird droppings. The COCCI mycosis is grown in soil. Often, if that infection is found in the lungs, it's very self-limiting, usually just mild flu-like symptoms. Histo is common in the United States. The COCCI is commonly found in Southwest area, Mexico, Central and South America. Blastomycosis is a rare infection that may develop when people breathe or inhale a fungus called Blastomyces dermatitidis, found in wood and soil. If left untreated, this disease is fatal. That last one, aspergillosis, found in the environment, rarely cause of a disease, and it can be found in molds or organic matter. So anyway, treatment is with antifungal medications. Depending on the severity and the complications, the patients may need either bronchoscopy, go in and clear out the area, or even a lobectomy, or treated with the antifungal medications. So that ends our content for fungal infections.